We now move into disorders of the endocardium. We have been through pericarditis and disorders of the pericardium. We've looked at coronary artery disease, and then we looked at cardiomyopathies, disease of the cardiac muscle, and now we've moved fully into the heart with that inner layer of endocardium. It's primarily focused on valve disorders, but these first two conditions I have listed here are really conditions that affect valve function beyond genetic issues, developmental issues with regards to excessive blood flow and heart failure issues and so forth. So I just want to talk very briefly about these. The book goes into a lot more detail beyond the scope of even what I'm asking you to know. So you know, kind of what you're getting in the lecture here is what you need for these two conditions. The first one is infective endocarditis. In infective endocarditis, we're really talking most commonly about a staph or staphylococcus infection. Staphylococcus aureus is the most common one, causing an acute conditions. It can occur in people who have had pre-existing congenital heart conditions or genetic disorders within the heart, which makes their heart already vulnerable to infection, but it can also form in perfectly normal hearts. And we do see it as a fairly common condition in IV drug users, so the development of a bacterial or viral infection, particularly bacterial, within the inner layer of the heart. Because the endocardium covers the entire inside of the heart, including the valves, and continues up into the blood vessels of the aorta and pulmonary trunk as endothelium, this condition can spread throughout circulation if left unchecked. Manifestations of infective endocarditis are linked to that, again, primarily bacteria, primarily Staphylococcus. They grow in what we refer to as vegetative lesions. These are clusters or colonies of bacteria. They like to grow on the valves, particularly atrioventricular valves, those valves that have the flaps. And when the bacteria grows on there, it leaves the valves dysfunctional and actually can completely destroy the valves. If you destroy the valves, you really have big issues with the flow of blood through the heart. That's definitely going to lead to profound heart failure. The other risk you have with infective endocarditis is that those bacterial clusters, those colonies, can cluster into fairly large clumps, and they can break free from the valves. If we're on the tricuspid valve, that cluster of bacteria becomes an emboli. It may flow to the lungs and cause a pulmonary embolism. If we're looking at the bicuspid valve, the risk is that it will flow up through the aortic valve, and it's not that the semilunar valves can't have them growing there, they're just more vulnerable on the flaps. But this cluster can flow through the aortic valve up into the arch and ascending an arch of the aorta. And then your biggest risk areas to go if it goes up either the left or through the brachiocephalic trunk and into the right common carotid. So left or right common carotid is going to lead to the brain, and you're going to have an embolism that travels to the brain, leading to a stroke. Infective endocarditis, primarily Staphylococcus infection, Staph aureus, usually acute, can be life-threatening. Manifestations are significant, particularly with the possibility of development of stroke or pulmonary embolism. Rheumatic heart disease, I'm really trying to simplify this one up for you because there's a lot of detail on this. I tend to ask very little about it on the exam, and other than what I'm giving you right here. I need you to know the cause here is a Streptococcus group A beta hemolytic throat infection. Streptococcal infections can occur elsewhere in the body, but rheumatic heart disease, RHD, is most commonly linked with the strep infections that affect the throat. And so you've all heard of strep throat. You yourself may have had strep throat. The development of rheumatic heart disease is most commonly linked to use of antibiotics incorrectly or never being treated for the disease. It's not nearly as big a problem in the United States because we do have antibiotics to treat the strep, and the physicians really beat it into their patients. You better finish all this medication. And so they actually overprescribe to the point where they're certain that even if you didn't take the last couple, you might still be certain to be protected because of the threat of development of rheumatic heart disease. The disease can be broken into three different acute, recurrent, and chronic. Not going to get into, it's a little confusing even how the book describes that. Acute rheumatic heart disease is linked to the inflammatory response that comes with the initial streptococcal infection, particularly again if it's not being treated at all, and the strep continues to grow. It can infect the endocardium, particularly the valves. Again, rheumatic heart disease is really an endocardial disease. It's the inner layer of the heart. It can affect all of the heart, but primarily it affects the inner layer. In recurrent, that you have that ongoing kind of coming and going of that same inflammatory response. And then the chronic condition of rheumatic heart disease can occur 10 years, decades later, as the damage was done and slowly progresses over a very long period of time. Either way, it is absolutely linked to poor treatment with regards to a streptococcus infection. So the next time you get strep throat, please be sure you complete your medication. All right, so let's take a look at our valve disorders here for the endocardium. What I need for you to do with this one is I need you to take some time and really read through the information that's in the book, because what I'm wanting you to do is have a basic understanding of what will happen to stroke volume, cardiac output, preload, afterload. Is there effect on blood pressure and heart rate for each of these 4 valve disorders? And they're basically just the 4. Mitral valve prolapse is a more minor condition. We'll talk about it in just a second. But just to give you first a little bit of a definition going here. When we talk about a stenosis, anything that is a stenosis is a narrowing and stiffening of the valve. A regurgitation is often referred to as an insufficiency, and in that case the valve flops backward and blood leaks out. So either condition can be diagnosed through auscultation. In other words, with a stethoscope you can listen and you can hear it. Ultrasound will allow you to help you to diagnose a stenosis versus a regurgitation, and echocardiogram. So you can hear it through auscultation, you can see it on an echocardiogram or on an ultrasound. Those are how you would diagnose those valve deficiencies. We focus on just the aortic and the mitral valves. That doesn't mean that you never see it in a pulmonary valve or never see it in a tricuspid valve, but we were really primarily concerned with the left side of the heart, and these are the areas that most commonly occurs. So I'm just going to kind of quickly walk through some of the effects that occur with each of these. But what you need to do is go read through the book, read through the summary. The book does a really good job on describing what really happens with each of these conditions. Almost all of them are linked to possibly rheumatic heart disease, and when you look at causes for them, they're all pretty much the same. It can be a congenital problem, an infection, even infective endocarditis can lead to these sorts of things, the side effects after recovering from it. So in terms of the causes, they're all relatively the same kinds of causes. It's very, very rare that I can give you a unique cause. So I'm really focused here not on cause, but on manifestations. And again, stenosis is narrowing, regurgitation is a backflow or insufficiency. So let's start with mitral valve stenosis. In mitral valve stenosis, you will see hypertrophy of the left atrium. Again, because the valve is narrow, blood is backing up into the left atrium because it can't get through the valve. There may be atrial fibrillations because the blood is backing up. So by fibrillations, it means it kind of quivers. So the heart quivers instead of contracting effectively. It has to do with the atria filling with blood because the blood's backing up from the left ventricle into the left atrium because it can't get through that narrowed mitral valve. That will eventually leave it back into the lungs. That leads to pulmonary edema and pulmonary hypertension, and that leads to left-sided heart failure. So when you have left-sided heart failure, you can see stroke volume go down, cardiac output go down, preload goes down. The heart rate may try to increase, but again, there's going to be a bit of a fibrillation, so it will be ineffective. Blood pressure, in terms of the blood pressure, we're really talking about pulmonary hypertension here. The only thing I would say that is not affected in mitral valve stenosis is your afterload. From there, let's talk about aortic valve stenosis. Oh, one other thing to mention with mitral valve stenosis, there also can be an increased risk for the development of thrombus and emboli, leading to an increase in stroke because, again, blood's not getting through. It pools out, not so much in the left ventricle, but in the left atrium. But eventually the clots can make their way through and can flow up to the brain. So there's definitely a risk of emboli and increased risk of stroke with mitral valve stenosis. In aortic valve stenosis, again, think about what's happening. You have a narrowing of the valve. If you have a narrowing of the valve to get the blood out, that's an increase in afterload, because now, remember, we have to afterload the force that's necessary to pump the blood out of the ventricles. With a narrowed valve, you got to pump a lot harder to get blood out. You're going to see a decrease in stroke volume. You're going to see an issue of chest pain, angina developing here. Again, stroke volume and cardiac output. So if you have stroke volume that drops down, you will see a decrease in cardiac output as well. Your preload is going to actually increase because blood's going to start to back up. So because blood can't get out the aortic valve, it starts to accumulate within the left ventricle, and it can eventually even back up into the left atrium and back to the lungs because blood simply cannot make it forward. You actually start to see a significant decrease in blood pressure system-wide because you have less blood pumping out to the body. Initially, the heart rate may increase. Again, these conditions very rarely develop overnight. It takes time, so heart rate may be unaffected for a while, but the heart rate may start to increase in an attempt to compensate. But as you start delivering less and less blood out to the body, that's going to affect the amount of blood that can flow into the coronary arteries, and with that you will eventually see a drop in heart rate. So it increases maybe somewhat initially, but then it drops. That gets a little hard to describe, and so because you wouldn't know where you are in the progression of the disease, so I tend to not ask a lot about the heart rate in this particular condition. I would much more focus on stroke volume, cardiac output, preload, and afterload, really for all of them. The blood pressure can be very important. Heart rate's a little less. Whenever blood pressure drops low, heart rate starts to increase. That's the normal reaction. But with the aortic valve, as the disease progresses, that heart rate can start to slow down. Mitral valve regurgitation. So yes, we're now into the regurgitations. Let's start with mitral valve regurgitation, and this is a condition in which the heart does not, the mitral valve does not close correctly. So we actually see in this case an enlargement of the left atrium to compensate for the amount of blood that keeps flowing back and trying to get it forward. The heart's really an amazing thing, and particularly with regurgitations, it will overcompensate so that for a long time this may not even manifest itself. It may not, the valve's not closing correctly, but the amount of blood that flows in will increase. The left atrium will enlarge to try and bring in more blood. So the blood keeps flowing back, but then it'll pump some forward and some will go back, but we'll send more forward, and the body will compensate for that. The left ventricle will enlarge as well to try and maintain cardiac output. So eventually, in mitral regurgitation, the cardiac output and stroke volume will drop, but preload will increase in order to compensate for that. So we don't actually see a significant change in blood pressure until this is really progressed over time. And afterload is unaffected here because the blood we don't need any greater pressure to get the blood out. We simply just have this issue of the blood pumping backwards. And in fact, there may be some hypertension that starts to develop over time as it tries to overcompensate for it. In aortic regurgitation, we see this in conditions. All the others have been, rheumatic fever is the cause, other diseases, genetic conditions with valve problems. But I'd like to point out that with aortic regurgitation, we also see this commonly in Marfan Syndrome. Remember that autosomal dominant disease that we talked about at the beginning of the course, where we have extensive connective tissue disorder, and it interferes with heart function. It particularly can affect the aortic valve and particularly result in aortic regurgitation. In aortic regurgitation, again, the heart's really good at trying to compensate, so it will significantly increase stroke volume in order to compensate for the backflow. Because think about what's happening. Blood gets pumped out through the aortic valve, and then as blood flows back down, as the pressure starts to drop, the cups should catch the blood and close. But if the flap gives way and blood starts flowing back down the ascending aorta and back into the left atrium, then you have less blood going out than you needed to. So that's a real problem. What the body will do is start pumping out more blood, increasing cardiac output, increasing stroke volume to try and compensate for the fact that the blood starts flowing backwards. So preload increases, stroke volume increases, cardiac output increases, all of those things in an attempt to compensate. Certainly over time, you can see this become a problem as the blood continues to flow backwards and the demands of the body cannot be met. So as the condition worsens, that will eventually lead to, again, all of these lead to heart failure, but it really can lead to a problem of not meeting the needs of the body. So initially, stroke volume, cardiac output, preload all increase. Blood pressure, blood volume may even increase, but over time that will start to diminish. One thing that's very unique about aortic regurgitation is that because of that increased stroke volume, you will have an elevated systolic pressure. So think about the effect on blood pressure here. Your systolic pressure may be very high, and then your diastolic pressure may drop very, very low. Think about what you do with the blood pressure. You listen for turbulent blood flow, and when the blood starts flowing smoothly again is when the sound stops. Well, the turbulent murmur that you're listening for at the end, those Korotkov sounds, may actually persist practically to zero because of that backflow of blood. So because you send so much forward and then it's starting to flow backwards, you have a high systolic and a very low diastolic. That's probably the most unique thing in terms of blood pressure. I mentioned in mitral valve stenosis, I'm very concerned about pulmonary edema and pulmonary hypertension. But in aortic regurgitation, we actually see that very unique blood pressure situation of a high systolic and a low diastolic. It can persist almost to zero. So please, again, read the information that's in the book so that you have a little bit better sense of it. My questions are really about stroke volume, cardiac output, preload, afterload, and to a lesser extent, blood pressure and heart rate. Those are the things I want you to be able to talk about. So again, the blood pressure is really more for the mitral valve and the aortic regurgitation, those two pieces there. Heart rate, just understanding that the heart, when it doesn't get the blood that needs, will start to increase heart rate, but over time that will eventually lead to a drop as the demands of the body aren't met and the heart can't sustain a faster rate. Mostly the other factors are what's important. Mitral valve prolapse, sometimes called the Floppy valve syndrome, is not as severe a condition as the stenoses and regurgitations we just went through. It's usually just the posterior flap of the mitral valve. It's often congenital, far more common in females, although it is also associated with Marfan syndrome, which is a condition much more common in males. It also can occur in hypothyroidism. Remember the myxedema, those mucins that can form when you have myxedema, those proteins that form in the extracellular space and cause edema to form. The mucins that are found there can reside on that endocardium and affect that mitral valve. In many cases, there can be just a minor heart murmur. It's often asymptomatic. As one gets older, it may cause some fatigue, a little bit of shortness of breath, but for the most part, it's a more minor condition. Some chest pain may occur, and usually mitral valve prolapse can be repaired with surgery. So So that shows. This is showing some of the pictures of some to kind of help you with these valve disorders. To kind of just take a look at how the valve and the flow changes a little bit with each of these. You know, the difference. Here's that aortic valve regurgitation with that compensation going on. So these are more just images to kind of go with some of the pictures and things that are already in the book. And that takes us to the end of this lecture. Heart failure is what we're going to look at in the next lecture.